Professor Sanjay Desai is one of the top and famous shoulder and elbow surgeon, not only known in India as a pioneer of shoulder surgery and founding member of Indian Arthroscopy Society and the Shoulder Society of India, but also known internationally with current position as a president of Asian Shoulder Association, in which by his contribution in 2019, he has been named as the recipient of Dr. B.C. Roy Award, which is considered the highest award of medical science by the President of India. Tonight, Professor Sanjay Desai will present I think the very interesting topic about the management of a massive irreparable cuff tear. So the time and place is yours.
Thank you very much for those kind words, Dr. Jeffrey. Professor Harmawan, Dr. Jeffrey, Dr. Rinaldi, and all my friends in Indonesia. It's a special honor to be part of this webinar, particularly because Indonesia holds a special place in the hearts of every Indian because of a lot of commonalities between the two countries, and we go back to hundreds of years. So it's a special privilege, and I thank you and thank the Indonesian Shoulder and Elbow Society for the invitation. Now, these are some of the hospitals from where I function, and that's the very tip of Mumbai where I function from. My talk is going to be simplified as much as possible, and I will address three important aspects of massive rotator cuff tear. Number one, how do you clinically diagnose a massive cuff tear? How to interpret the MRI and come to a conclusion that this tear is probably irreparable. And then the treatment options available for massive cuff tears and the criteria how to select which modality of treatment is best for that patient. So these three questions will be answered in my talk as we go along. So the first thing I want to point out to you is that in my experience, massive cuff tears which are truly irreparable are few in number in this part of the world, unlike perhaps what you see in the European or American population. So if you have 100 massive tears, it is a great relief to know that out of 100, only 18 may look like massive irreparable cuff tears on MRI. Out of those 18, you will find that almost 8 out of those 18, so about half approximately, will be repairable, though you thought that they are irreparable. And only 10 out of those 18 will be truly irreparable massive cuff tears. And if you break up that 10 age-wise, majority are elderly, more than 70 age group, and a very small percentage is relatively young population. So that's the overall demographics of massive cuff tears. So the most important slide is this one, that many of those which look like irreparable massive cuff tears are often repairable. Here is an example on MRI. This looks like a massive supraspinatus tear with a subscapularis tear, and you may think that this is going to be irreparable, and to your surprise, this was fully repairable. So have a look. The cuff has retracted all the way back to the glenoid and looks a little unnerving even on arthroscopy. and see when I check the mobility of the two leaves of the cuff tear, the anterior leaf, posterior leaf, and you'll be surprised that I could repair the tear completely. Now, as against that, here is an example of a massive, truly irreparable cuff tear. And you can see in the MRI, the age of the patient is 75. So most of these patients are above 70. So this is what a truly irreparable tear look like on MRI. So there is a massive supraspinatus tear. You cannot see any tendon tissue. You can only see the muscular belly involving the supraspinatus and the subscapularis. Now, how to clinically diagnose a massive cuff tear? These are just few of the tests available in the market, but it is but obvious that it's not possible to do all these tests in a busy clinic. So I'm going to pick and show you the test which I do in my daily practice. So first, to test the power of supraspinatus, we do the Job test. You apply resistance to forward elevation. It may not be specific for supraspinatus, but it gives you a reasonable idea whether supra is intact or is torn. Of course, you have to keep the pain factor in mind. Have a look at an external rotation lag sign. It's a lovely video. I love this video. I passively externally rotate, ask the patient to maintain external rotation, and the patient is unable to maintain. It drops back into internal rotation. This is a classic sign for infraspinatus tear with the arm adducted. So the patient is unable to use his supra and infra. He cannot externally rotate, so he abducts the arm in order to drink water. See, then he can externally rotate, only in abduction. So this is the MRI of that gentleman. He has a supraspinatus tear and an infraspinatus tear. He is young, but I could repair this completely. Now it is interesting to note that nature has given many internal rotators. In all, we have 4 internal rotators: the subscap, the pec, the teres and lat dorsi. And as against that, nature has given only 2 main external rotators, the infraspinatus and the teres minor. So when your tear is extending from infraspinatus into teres minor, it is an extremely disabling situation because you have difficulty in external rotation, and hence common activities of daily living are severely affected, like eating, drinking, combing hair, and controlling your arm in elevation. So this is the hornblower sign. Teres minor is an external rotator of the shoulder with the arm abducted. So this is how you test for teres minor. Now it becomes very simple and easy to clinically judge a massive tear. If you have the supraspinatus test which is positive, you have external rotation lag, you already know that it's a massive tear. And then next step is to assess the subscap. So the lift-off test, we all know the Gerber test, but often the patient is unable to internally rotate as much because of capsulitis, which is associated with cuff disease. And therefore you have other option of a Napoleon sign. As you see here, you ask the patient to compress on the opposite shoulder and you try to lift the arm off the shoulder. This is the Napoleon sign or the belly press sign. So these signs for subscapularis are usable when you have a stiff shoulder and the patient is unable to do the lift-off test. So if you think rationally, it is clinically possible to diagnose one supraspinatus tear, infraspinatus tear, subscap tear, and teres minor tear. So you really need no imaging to come to a conclusion that it's a massive tear. Dr. Rinaldi gave a very nice talk on sonography. You can use that as a means of confirming what you clinically suspect. But MRI might be required in surgical planning as well as prognosticating the result. So when you have severe fatty infiltration, which is slide number 3, picture number 3 and 4, where more than 50% of the muscle is substituted by fat, then it's a red flag, because this muscle may re-tear even if you repair it nicely. Or if there is severe atrophy, which is stage 3 of Didier-Pathé, in stage 3 again the muscle is atrophic and a very high risk of a re-tear. Retraction, not very reliable sign in terms of repairability. I showed you a video of a cuff tear where the cuff had retracted all the way to the glenoid, but it was fully repairable. So these are the 3 important radiological features on MRI which should warn you about a high risk of a re-tear. If you have fatty infiltration, Gottalier stage 4, where more than 50% of the muscle is replaced by fat. If you have stage 3 atrophy and retraction up to the glenoid. These signs indicate that there is poor healing even if you try to repair, and there is a very high risk of a re-tear. So now there are many reasons why I will not repair a massive cuff tear. So here is a list. If there is no tendon, it is resorbed, like I showed you an MRI example. If there is fatty infiltration or atrophy, so no tendon, no muscle, very poor bone, very arthritic joint, or a static humeral head riding high under the acromion. And it's static, it's not dynamic. And patients who had multiple previous surgeries. So these are situations where I will be reluctant to repair the cuff. And thank God that these kind of situations are seen mainly in the very elderly age group and not so common in below 60 age group, as I showed in my initial slide. So what are the treatment options? We go to now question number 3 and address that. What are the treatment options and how do you select when you treat a massive cuff tear? So you have many options. You can do just a partial repair, even if you're not able to fully repair, with or without a long head of biceps tenotomy. There is a biodegradable balloon which is available. It's a concept which originated from Israel. The balloon is placed in the subacromial space. Effectively, it is pushing the head downwards. It is substituting the job of the cuff. It pushes the head down, and then the deltoid can be used to raise the arm up. And now we have tissue patches such as fascia lata or synthetically made patches, what is called as superior capsular reconstruction. I will talk about it in a few slides a little later. And then we have muscle transfer, a trapezius or a lat dorsi transfer for massive tears. And then you have reverse shoulder arthroplasty or reverse shoulder arthroplasty combined with lat dorsi transfer. So these are the options for massive irreparable cuff tears. And now in the next 4 or 5 slides, I'm going to tell you how to select the modality of treatment out of these. So the key issues to consider are, number 1, in a situation with massive cuff tears, sometimes the shoulder is still functional because the muscle balance is preserved. So is the shoulder functional? Number 1. Is the long head of biceps present? And is it thickened and hypertrophied in an hourglass deformity? And if the shoulder is imbalanced, which means a non-functional, then the loss of function could be either in one plane, which is forward elevation, or it could be a loss of external rotation only, or a combined loss of forward elevation and external rotation. So these are the factors you have to assess clinically and radiologically to decide which modality of treatment from that list you would select. So the clinical presentation of a patient may be just a painful shoulder, but it is functional in the presence. All these are massive cuff tear patient presentations. You can have an isolated loss of function in terms of forward elevation. You can have an isolated loss of external rotation or a combined loss of forward elevation and external rotation. So group 1 is a functional but a painful shoulder, and group 2, 3, 4 is a painful shoulder associated with loss of function, different patterns. And therefore, you will select from this list of 8 options accordingly. So if you have a functional shoulder, then you would consider a partial cuff repair with or without biceps tenotomy. If a balloon is available, you could use that. A tissue patch like fascia lata of Mihata, and superior capsular reconstruction if that synthetically manufactured patch, dermal matrix patch is available in your country.
Sorry,
As
Prof,
against
I have
that,
a
if you
2 minutes.
have a non-functional shoulder, then you have to choose between muscle transfer, reverse shoulder, or reverse shoulder with a muscle transfer, depending on the age of the patient. So good function, elderly patient, I would select the top 3. Good function, but a young patient, I would select a tissue patch, a fascia lata, or a muscle transfer. And poor function in an elderly, I would do a reverse shoulder arthroplasty. So this is how I would cater to this massive cuff tears depending on the function of the shoulder, the presentation of the shoulder, and whether the patient is young or elderly. Now, here is an example of a massive tear in an elderly. It's irreparable, but the patient has good function. So what did I do? I did a partial repair because I could not repair the whole thing, along with the biceps tenotomy, and the patient did reasonably well. In contrast, if you have a massive irreparable cuff tear in a relatively young patient, this is 54-year-old, he has a massive supra plus infra tear. In this case, I did a lat dorsi transfer. I would not consider a reverse shoulder arthroplasty because the patient is young. So you have to choose between lat dorsi or trapezius transfer or a patch, whether fascia lata or synthetic, depending on the circumstances and what the patient expectation is and what training you had to execute the job with perfection. So the same patient that I showed you, 54-year-old with a massive supra-infra tear, you could do a muscle transfer or you could do a superior capsular reconstruction using either fascia lata or a dermal matrix patch. As you see in this diagram, this concept introduced by Teruhisa Mihata from Japan. And what his experience is that it does restore superior glenohumeral stability. It pushes the head down, it keeps the head down and provides a substantial improvement in pain and function. There are certain criteria, or the technique is demanding. You need training and experience. The graft thickness has to be minimum 8 mm. The shoulder abduction should be between 15 and 45 when you do the superior capsular reconstruction. Some technical details about the graft length that you need. So these are all technical issues which you need to be familiar with if you plan to do a superior capsular reconstruction, either using the fascia lata or the dermal matrix patch. So Stephen Burkhardt has done some extensive work on the dermal matrix patch, and he also has experienced that it is a useful procedure and it does improve function and relieve pain, published in 2017. Now, if you have a massive tear and the patient is elderly, say 70 and above, and it's a massive tear with poor function, then I would not hesitate to go ahead and do a one operation, which is less likely to need a second operation, and therefore it will be a reverse shoulder arthroplasty. Massive cuff tears without glenohumeral arthritis, which is Hamada 1, 2, 3. So a non-functional shoulder with a massive tear in the elderly, then that is Hamada 1, 2, 3, and you have chronic loss of elevation for more than 6 months. This becomes an indication, even if there is no arthritis, for a reverse shoulder arthroplasty. It is US FDA approved in patients above 70. Now beware, if you have pseudoparalysis, which means less than 90 degree of forward elevation and full passive range of movement, in patients with pseudoparalysis, you will have improvement in pain, but the actual active elevation following reverse shoulder arthroplasty might reduce So you must counsel the patient beforehand when you're dealing with pseudoparalysis because of a massive cuff tear in the elderly. So here is an example of massive cuff tear in the elderly. It is irreparable with poor function, and I would do a reverse shoulder arthroplasty. And you can see that it's a very successful, effective solution. She has excellent forward elevation. She has good external rotation because her teres minor was intact. The massive cuff tear involved only the supra and infra, and excellent function with pain relief. These do well in a predictable fashion. What is the limitation of the reverse shoulder arthroplasty? It cannot provide, in the presence of cuff tear, and usually it is supra and infra, it provides forward elevation, but the deltoid does not provide adequate external rotation. And therefore, in those patients with massive cuff tears where you plan to do a reverse shoulder arthroplasty, if you have no teres minor, you should do an episcopo, which is transfer the lat dorsi simultaneously when doing a reverse shoulder arthroplasty. Otherwise, the patient will have poor external rotation following reverse shoulder and may not be very happy with the function. So here is a slide which summarizes massive irreparable cuff tear. If you have functional shoulder, you select what you see in the green circle. If you have a non-functional shoulder in the elderly, then you select the one in the red circle. Isolated forward elevation loss in non-functional shoulders, do a reverse shoulder. Isolated external rotation loss, you can do a trapezius or a lat dorsi transfer, and in combined cases, you have to combine reverse shoulder with muscle transfer. In summary, massive irreparable cuff tear is uncommon. If you look at the literature, you might get deceived into thinking that it's very common, but that's perhaps in the European population or the American population. But in our part of the world, it is relatively uncommon. Out of 100, 18 will be massive, look like massive. Out of 18, only 10 will be truly irreparable cuff tear. Many of these which look irreparable on MRI are actually repairable. So when I take up these patients, I counsel the patient that I will try to repair it. If I can't, then intraoperatively, I will switch to a reverse shoulder arthroplasty. So it's good to know this. I would do a reverse shoulder arthroplasty in the elderly and a muscle transfer or a superior capsular reconstruction in the middle age group. Partial repair is for limited goal surgery. I conclude my talk with one of my favorite one-liners. I'm not an arthroscopist because I cannot see pain through the arthroscope. And therefore, you have to be a good clinician if you want to be a good shoulder surgeon. I thank you very much. Thank you, Indonesia and the Indonesian Shoulder and Elbow Society. And special thanks to Erica and her team. Thank you.